at the conclusion. So you'll be getting a notification now that the event will be recorded. We just want to take a moment to thank Dr. Neal Davis, who has come to share with us today his experiences implementing a primary prevention screener in his primary care setting, known as SEEK, or Safe Environments for Every Kid. Dr. Davis is a certified pediatrician who has practiced at Hillcrest Pediatrics in Murray, Utah for 13 years. He is currently the Senior Medical Director for Pediatric Community Care for Intermountain Health, focused on population health services for children. After earning his medical degree at the University of Utah, Dr. Davis completed a research fellowship in general pediatrics at University of Michigan and obtained a master's degree in healthcare and healthcare research. His research focused on psychosocial risks in a child's environment and the related impact on health and wellness. Dr. Davis has served on the Board of Trustees for Intermountain Healthcare for 3 years and currently serves on the executive board for the Utah chapter of the American Academy of Pediatrics and Intermountain's Children's Health Executive Council. His personal mission is to unleash the joy and potential of each child. I absolutely love, Dr. Davis, that you add that little bit at the end. It's exactly kind of sums up what we're hoping to do with the work that we do in our primary prevention of adverse childhood experiences and child maltreatment. Before I turn the time over to Dr. Davis, I'd just like to acknowledge and recognize that he will be joined today by colleagues Dr. Tim Larson and Vanessa Waite from Red Rock Pediatrics in St. George, Tara Long from Intermountain Care Management, and Matt West, CEO of We Care Pediatrics, who will share their practical experiences employing this important primary prevention tool as well. So without any further ado, Dr. Davis, we'll turn the time over to you.
Okay, great. Thank you. Let's go ahead and get started. Here's a brief outline of the things that we hope to cover today. We do hope to save time at the end for questions, and also would encourage you to put questions along the way in the chat. And I think Joey's going to monitor that and stop me along the way so we can discuss those. Sometimes that's more interesting than listening a long time to someone talk. So I appreciate that. All right. So the outline is we want to review very briefly the reason.
Dr. Davis, we are kind of getting that muffled, hard to hear you. I don't know if you can kind of prop your computer up so we can get you closer to the mic. Sorry about that.
Yeah, good to know. Let me try this even. See if
that's perfect.
Is that better?
Yep, sounds perfect.
Okay, that's a little trick maybe I can remember in the future too. Is it sharing, or did that stop?
Yeah, it stopped sharing your slides, so you'll need to reach.
All right, let me try and figure out how to do that. Okay, can you see my slides now?
We see them, thank you. And we hear you.
Okay, good. Let's cross our fingers here. All right, so we'll start just by an overview of the reasons to think about addressing social determinants of health or social drivers of health. There are a lot of terms for this concept now, specifically as it relates to children. And then we'll talk a little bit more specifically about the SEEK model of care, the safe environment for every kid, and how that also relates to prevention of child abuse and neglect. Then we'll talk a little bit about Intermountain's experience implementing these processes in 17 pediatric practices across the state. And as part of that, we're fortunate to have Tara Long here, who was mentioned, helped with a lot of this work in a care management role. And then Dr. Tim Larson and Vanessa Waite, who have real practical experience being at the ground level doing this in St. George. And I think you'll appreciate that kind of real life perspective. Then briefly, we'll talk a little bit about, is there an opportunity to expand, and what are the barriers for doing so? And how does that impact other pediatric practices around the state? And that is from Matt West will contribute to that conversation. as the CEO of We Care Pediatrics, which is a great practice in Utah in the Davis County area. And then we'll review some take-home points and then have some time for questions. So that's where we'd like to go here. This is just a quick slide. This is something that people, I'm sure, have seen, and there are lots of versions of this slide and this concept. This is just clipped from Intermountain's care process model on social determinants of health. So it's a little fuzzy. I apologize about that. But the concept here is when we think about someone's health, and frankly, especially the health of a child, there are a lot of factors that go into that. And actual health care, on this slide, it says 6%. I've seen others that say 10% or 12%. But the point is, there are so many other things that really have significant impact on the long-term health and wellness that aren't traditionally in the box of healthcare. And I know that the people listening to this call know that. That's kind of a no-brainer. So when we think about a child, there's a concept that's important. That's the idea of LifeCourse theory. And that is, for children, it is often the case that there's a trajectory of health and wellness set very early that even extends into the prenatal period, and then certainly through the early childhood years, that tends to play out through the rest of life. And that's a very important concept to understand. And it's a reason why a focus on childhood and these ideas of social determinants of health and environment and ACEs and other things that you're familiar with are such a big deal, because the impact is significant over time. And that really has come to the attention more of pediatrics and medicine in general over the past few decades for a couple reasons. One, this is something you're familiar with already. This is the pyramid from the original ACE study, where they, as you all know, they looked at outcomes in adults that were very significant health outcomes, both behavioral health and physical health outcomes. And they found that people that had these outcomes, and this was cancer, heart disease, liver disease, all sorts of very difficult conditions, if they had adverse childhood experiences, and you know about these, when they were young, the risk of those things was significantly higher. And this is not like, you know, when we hear on the news that a certain additive has a 2% increase in stroke or something like this. This is like 2, 3, 4 times the risk of things like stroke, heart disease, cancer, mental health conditions. And so it's a very big deal. So when this came out, this was really important information for people to understand. And I think those of us that have worked in childhood areas, this was kind of a no-brainer. It was like, yeah, I mean, these kids that experience all the adversities, their lives and their life course, going back to this slide, is really disrupted. So not a surprise at all, but it was really nice to see that information come out in a way that people could wrap their heads around it for society at large. The other concept that has come to bear within the past couple of decades is this idea of epigenetics. And I think you're all probably familiar with this too. We know that our genetic code affects how we are and our health and our potential, our growth, all of these things. But what has really come to be understood more is how the interplay of an environment impacts with the actual genes. And you can see all this complicated stuff here, epigenetic factor and DNA methylation and so forth. But the point is, those types of adversities actually impact the expression of genes. And that is part of the reason for that life course trajectory difference that we were talking about earlier. So again, I know that's likely review for you, but an important thing as we get both kind of the social science merging with medicine and then the basic science merging with medicine to really understand how adversity impacts the long-term health of children. Okay, so now we think about, well, what can we do about it? And that's the most important thing when we have a finding. So today we're really going to focus on the idea of how can we impact and reduce risk, eliminate that so we can bump that trajectory up and promote resilience. So let me talk a little bit about the safe environment for every kid model. Okay, this was something that was developed, over the past 2.5 decades out of the University of Maryland in Baltimore by a researcher and his team. It was Howard Dubowitz was his name, or is his name, he's still there. And the idea is that a child comes in for well visits starting at birth. And this is really focused on birth up through age 5. And at those visits, there is a parent screening questionnaire given out to identify what might be some of the stresses in the environment of a child's life in their home and in the family. And then being able to identify and briefly discuss the situation, the concerns, being able to kind of triage the level of support desired, and then be able to respond to that in a team-based care approach that really heavily relies on partnerships with the community. And so that's the model. Oh, and importantly, being able to follow up as well. And I think, honestly, the secret sauce of being a primary care physician, and especially a pediatrician, is that follow-up and the relationships that you build over time with people that you honestly you grow to love and respect very deeply. And so this is the model. Here's a fuzzy picture of an actual questionnaire that was filled out years ago. Now we do more of this on computer, but you can kind of see, this is a parent thinking through things and marking different stresses in their life. On this one, you'll see things related to a smoke alarm or extreme stress, symptoms of depression in the parent that filled this out, and then at the bottom, some concerns about housing. And when you think about that information, knowing that if I'm concerned about the long-term health and wellness of that child, that's enormously important. And if we're going to avoid adversities, significant adversities, thinking about child abuse and neglect in particular, being able to understand the context and support the family is a critical piece to being able to support that child. So this is a slide that actually you can read and you can see the questions a little better. And again, now we have kind of an electronic way to get this information imported into our system, but originally we would have this done on paper, and then on the back end, our office staff would fill this out. We actually still have to have office staff that does that because not everybody remembers to do the computer process, and that's okay. We don't want to miss any kids. But this gives you a chance to see the actual questions. And I'm going to just show you here, the top part has a really, really important section. It's a little preamble that says, hey, being a parent's not easy, and we want to have a safe place for kids. We're asking everyone these questions. So this is a way to kind of normalize, like, hey, we get it. Being a parent in a family is a challenge. And if there's an issue that we identify, we'll try to help. And then, you can answer these questions about your child being seen today, or if there's another child in your home and they may apply to them, you can answer yes to that too, and we'll do our best to support you. And then importantly, this is confidential unless we're worried about your child's safety. And so it's there written for parents. So just very quickly, there are sections related to kind of home safety, and it's meant to start gently. Like, hey, these are questions about being safe at home. And then you'll notice in the questionnaire, it progresses to things that are a little more intensive and very important. So kind of home safety, secondhand smoke exposure. Then we get into 2 validated questions on food insecurity. Then this is something that we have added at Intermountain to the SEEK questionnaire with their permission, question about transportation and housing, because CMS has identified those as critical domains. Well, not because of that, those are critical domains, but also CMS is asking about those. And then there's some questions here about kind of harsh discipline and do we need support in caring for the child? And then moving on to extreme stress. I have to tell you that this question is, over the years, one that I have come to really rely on. If I see a parent marks that question about extreme stress, that's a red flag to me that there's something I really want to talk about to support that family. Then there's a couple questions there related to depression. For the parent or caregiver who's filling this out. Then a couple questions related to domestic violence, intimate partner violence, and then some questions related to substances as well. So that's the questionnaire. And again, you can see how it progresses from gently to more intensive, which is intentional and I think important. Okay, so this questionnaire is given out at the 2-month, 9-month, 15-month, 2, 3, 4, 5-year-old visits, because things change over time, and it's important to stay connected to families, and we'll talk a little bit more about that. Okay, so what are the results? Let's get to that really quickly here. Howard Dubowitz and his team did a randomized control trial in Baltimore with an intervention group that used the SEEK model to identify needs, have brief discussion about it, and connect to supports when desired by the family. And then another group that was regular care, where they got information about these same kinds of things, but they didn't have the model to really identify and discuss. What they found, and this was the big kind of headline finding, is that in their intervention group, there were fewer reports to Child Protective Services, and that was statistically significant compared to their regular care group. And that's a 31% reduction. So they partnered with their state Child Protective Services to be able to get these outcomes, which is pretty innovative and was not easy to do, but very important. And then they had subjective outcomes as well. They asked parents about how they were disciplining their children and so forth. And they noticed that there was a very significant decrease in what parents were reporting related to how they were interacting with their kids. There were more outcomes. These are just 3 of the big ones. And then this third one is actually quite important, and we'll come back to this as well. The group that had this intervention actually had higher vaccine rates compared to the other group. So what does that mean? And that's an important question that we'll come back to. All right, so the next question is, if you present that data to some primary care pediatricians, the first thing they'll say is, that's nice, don't have time for that. And that's, to some extent, kind of true. So what they found here in a second study, where they went out to the community and they said, okay, let's actually measure the amount of time it takes to address these psychosocial issues. And there wasn't a difference in the groups that were using the SEEK model versus ones that aren't. And I'll tell you, at first, it's like, how can that be? But after doing this for years, once your team, and I say that really is a team, has a system to be able to identify and work through these things, you'd much rather identify them early than in crisis, because you see them. And then there's a crisis. It honestly takes a fair amount of time, and you don't necessarily have a way or a plan to navigate all of those things. So to me, this makes sense, even though at first you're like, how does that work? And then this one makes a lot of sense. Providers over time and their teams had more confidence in being able to navigate some of these difficult situations. That doesn't mean that we always feel very confident about all of this work. This is work that's hard, and but definitely an improved confidence in doing this very important but difficult work. Okay, so Joey brought this up when we were talking actually just recently, like, hey, you know, we looked this up, and the California Evidence-Based Clearinghouse has this rated really highly as an intervention to prevent child abuse and neglect. And yet the USPSTF says it's indeterminate, not enough information. So how does that work? Well, a couple things. The California Clearinghouse, you'll notice, is really focused on the prevention for child welfare, information and resources for child welfare professionals. It's very squarely focused in on the issue of prevention of child abuse, neglect, and supporting families in that way. And I'm not saying that that USPSTF is not. I'm just saying they're a little more focused on medical outcomes, and they also require multiple studies. That they, to their credit, I think, have a very high bar of when they will say, okay, this is a grade B or a grade A evidence. So I think that's important context to understand. Those are the studies we have now, and that's how different groups are looking at it. All right, a couple other things. So this model, the SEEK model of care, overlaps to a certain extent with all of the trends going on in our country related to screening and supporting efforts related to social determinants of health. And we're seeing those forces pick up nationally. So on the inpatient side for health systems, if you didn't know, CMS, so Center for Medicare and Medicaid Services, it's actually CMMS, but whatever. they are really driving this now. And in 2024, they are requiring all hospitals to do screenings for social determinants of health for people 18 years and older. So I think they're still trying to figure out what to think about kids in that way. And then the Joint Commission that accredits hospitals is also coming out with recommendations related to this. On the outpatient side, which is more the community side that we work in, there's a group called NCQA. They set standards related to measures and other things, and they provide what's called patient-centered medical home accreditation. And they are now more and more requiring more strictly efforts related to social determinants of health. They're imposing that. Imposing is a tough word. They're requiring that also of health plans. And they just this year, I think last month actually, came out with the HEDIS measure. HEDIS is a big thing in medical outcomes. It's how all the insurance companies say, this is how we're managing our population. That gets filtered down to us as medical providers who have to say, hey, this is how we're caring for our populations. And just last month, they came out with a HEDIS measure related to social determinants of health that involved being able to inquire and understand housing, transportation, and food insecurity, those three to start with. And my guess is they're probably going to expand that in the future. There's a whole guide to how they recommend approaching this. But the point here is this is coming for healthcare. And so from my perspective as a pediatrician, I would rather think about doing this in a way that has stronger evidence for children that relates to social determinants of health, but also can help support the family and potentially avoid child abuse and neglect. It's not going to prevent all child abuse and neglect. I totally get that. But if we can actually get at some of the root causes and support families and avoid some of that, that would sure be a miracle, actually. So some of the timeline here with Intermountain and the work with social determinants of health is, as a system, got together more like in 2015 and started working on putting together what's called a care process model so that we had a method for working on this. And that was published in 2017. Then in 2019 through 2021, you may have heard about this. Intermountain partnered with different communities around the state to support the communities in doing this work so that the medical offices could help identify different social determinants of health using the SEEK model and another screener that I'll show you in a second, and then being able to have those community partnerships to respond. Another thing to mention is this platform called Unite Us. This is a data platform so that when needs are identified, medical systems can interact with community-based organizations, and community-based organizations can interact with each other with referrals and communication with the appropriate consent. That's very important, but being able to make sure that when we're sending referrals for food, for example, that we're able to understand that the family got that support or what we need. There's also been a lot of collaboration with Utah 211, being able to support that, to be able to manage more needs. So again, if we're gonna go after identifying these things, being able to have a good enough response is important. Being able to have this is just a little pearl, having a perfect response means you'll do nothing. So having a good enough response is what we're after in this work, in my opinion. But if we wait until we have things perfect to be able to identify and support these families, in my experience, nothing happens, and you never learn, you never grow, and you never really make a difference. So, okay. Another thing is social impact investing. That's something that Intermountain has done for housing, for example, which is a critical need. And then there's an entity that Intermountain developed called Castell. It's underneath Intermountain, yes, but a little bit separate in the sense that it's managing population health. And I saw one of my Castell friends on here, Ashley McDonough, which is great. So there's a team of people that were created to help support population health, and that's vaccines and other things too. And also when we identify these critical needs, being able to have a team that can follow up and connect to services and things like that. That's a little bit of the journey there. This is just a brief review of an algorithm. When we identify something, this is kind of what we do. We repeat the screener in a year. There's another slide in just a second that Tara is going to talk through. So Tara, this is cue you up to come off mute, because I think it's important to kind of understand how this actually goes in a workflow. So Tara, I believe I saw you were on. If you want to talk through this one, that'd be great.
Yeah, good afternoon, everyone. Neal, can you hear me okay? And folks
Yes.
on the call? Okay, perfect. And I apologize, my camera's not working. It's on and just black, which is a shame because I'm having a great hair day today. So no, I'm just teasing. Anyhow, Neal introduced me at the beginning, but let me just again let you all know who I am. I'm Tara Long. I'm the Director of Care Management for Children's Health and Primary Children's here in Utah and Salt Lake Valley. So nice to meet you all. So as Neal mentioned, we have kind of a global social determinant screening process in our primary care clinics across our Intermountain system, both in pediatrics as well as family medicine and internal medicine, just for clarity. And where we start is the patient will fill out the social check screener via paper form, or it could be launched to them using this kind of robotic kind of launch system that we use, where the parent may get a text a couple days ahead of the appointment with a link asking them to complete some intake paperwork. One of those intake documents would be the social check or the SEEK form, the social determinant screening tool. So through either pathway, the medical team, the MA, the provider, sometimes a care coordinator will be reviewing these results, kind of upon the patient's arrival, or sometimes it happens before the patient checks into the clinic. So the first decision point here is, does the patient have a need? Did they indicate a need based on that screener? If no, that process kind of ends there. There may sometimes be, it may extend just slightly beyond that, where the provider and or maybe the nurse or the MA says to the family, thank you for completing the screener. We've got it right here. Looks like things are going well at home right now. And then it kind of ends right there. If there are needs, the next question the team is asking is this a high-risk need, and does it pose imminent harm to the patient or family? If yes, that is immediately escalated to the physician or the APP, and a consult with the care manager is implemented or ordered. If there is not a high-risk need, we still are asking ourselves, does this family require immediate assistance? So things that might be more immediate as opposed to urgent might be food, worries about housing or paying rent or paying utilities, mental health sort of needs. Those would be, kind of immediate, but maybe not urgent. In that case, we may be providing the patient with a referral and information to resources on 211. We have a couple methods in doing that. One of those that has been very effective is helping the family download the 211 app while they're right there in front of us in the clinic, and helping them learn to kind of navigate that. Put in their zip code and their address so that they can learn how to access resources close to home. If the patient, excuse me, I kind of went in the wrong direction here. If there's not immediate needs, we may give them just this backup 211 information in case something comes up. If there are more immediate needs, we're connecting the family right then and there to an online platform called Unite Us, which links us to a coordination center that will help connect families to community resources. This coordination center will reach out to the family themselves and kind of assess what the needs are based on the referral they received. They'll also ask about additional needs and then help the families connect to those resources in the community, as well as provide a follow-up call to them to see, was that a successful resource? Were you actually able to connect? Did that meet your need? And then this platform will document, or the coordination center will document in this Unite Us platform that is visible for the care team to see as well. And then, like Neal mentioned, we have kind of a sister company under the umbrella of Intermountain called Castell, where our care management teams are housed. So based on the patient's kind of insurance status, we may be sending a referral to the care management team under Castell as well. So the care management team and care coordinator will do some follow-up and perhaps a care plan with the family to help them connect to the resources needed. And then here's just a little outline of, again, kind of how we have stratified the needs or the concerns based on this screening tool. So minimal risk, we may just be things like poison control, smoke alarms, we may just be linking the family to 211. And then we kind of go down, you know, things get a little heavier as we move down. For education or dental needs, again, the care coordination team can link the family to those resources. For the medium risk needs, such as housing, food, and mental health, again, the care coordination team, the Unite Us platform, and 211 are kind of the resources we utilize there. And then for the high risk needs, homelessness, interpartner violence, substance use disorder, as well as unsafe or abusive, legally reportable issues, we connect with the physician or the APP as well as the care management team.
Okay. And Tara, that was great. And the coordination center in this slide, that's the 211 coordination center, correct?
It's the Unite Us coordination center.
Oh, okay. All right. And they collaborate with the 211. Is that
Correct.
right also?
Yes.
Okay. All right. Okay, very good. So there's been a lot of collaboration with 211 on this, and a lot of communities have now developed relationships with this Unite Us platform so that multiple entities in the community can use this platform and so forth. Thank you, Tara. That's great. Okay. So just really quickly, you can see over time, as we've been doing this for a long time on paper, but over the past few years, we were finally able to get this into coded fields so we could see, you know, how are we doing at our process? And I'll say that's pretty good, being able to implement a process and hold it to some level of fidelity, so that what you're looking at here is over the past several years, how many of kids who came in for a potential Seek well child visit actually got the screening done. And so that's what you're looking at right there. And that's a combination of the process where they can fill it out online ahead of time, or the paper backup process that we use. And then that was with pediatrics. And then here's family medicine. And so you can see that's there's a lot of variation there, and it's not as high. That we're actually doing that right now. So last week, family medicine went live with the online process for this. And so we're watching that closely to be able to support that work in family medicine practices throughout the state as well. Okay, so then when we break down the different domains, remember when I talked about the questionnaire, those different domains, this is kind of our positivity rate, and see how is it looking? What are we identifying? So in that home safety domain, that was like, you know, do they need the phone number for poison control? Do they have a smoke alarm? That kind of thing. Those are the proportion of people that are answering that question positively. Then you can see secondhand smoke, nutrition insecurity, and kind of what we're finding here. The kind of the harsher discipline domain. The major stress, again, I found that one to be such a useful domain. And then the proportion of parents that are marking significant symptoms of depression. Then we'll move here to transportation. You can see intimate partner violence, housing insecurity, and substance use. And the other thing that we've recently been able to develop is a way to look at this by clinic. So you can see what clinic populations, you know, are seeing more food insecurity, and then work with those care teams and make sure that they're connected well into the food bank or other things like that. And we do see variation in that way. And so that's just some of the initial just raw positivity rates just for this year. This is just 2023 data. Okay, so quick question. What about kids that are 6 and up? Seek was really developed for the younger kids. And honestly, it was developed that way because that's where the highest risk of child abuse and neglect is. And if we think about LifeCourse theory, it's just huge. Early childhood is huge. So 6 and up is also critical. This is the form that we use. It is, in my view, good, not perfect, but it's good. And we're still able to get information and identify and support families. And by 6 and up, I mean adults too. This goes all the way up through all ages across the board. Okay. All right. Tim and Vanessa, I know you are on. So you've heard kind of the theoretical slant from me and some of the data. But I really wanted to have Tim and Vanessa come. Tim is an amazing pediatrician. He's someone that cares deeply about his patients and thinks critically. And when he does something, he does it with full commitment. And so I have a ton of respect for Tim. And Vanessa is an absolutely outstanding practice manager with attention to detail and really implements processes as well as anyone I've ever seen. So I say those things sincerely. And I just, Tim, Vanessa, over to you. What was it like to implement this? What was tough? What were you worried about? And then what have you learned?
Thank you, Neil. It's kind of you to say. It takes one to know one. You're an inspiration to us all. The way that you approach practicing pediatrics, and especially in this area. So that's been helpful for us as we've implemented this, to learn from you and other people who have done this. As we started implementing, I think one of the biggest concern was, is this going to take a lot of time? Is this going to be really challenging, burdensome to manage all these psychosocial issues on top of the things that we already are seeing? And the more that we did this, I think I came to the realization too, like you said, that we already deal with a lot of this stuff, but we don't always know it. And if we get upstream on it, then we can start to put things in place that prevent a lot of those problems. And it honestly helps us with all of the other things that we treat too, because the medical things, the physical things are often the tip of the iceberg. How well parents can adhere to a treatment plan, how well they can follow up, how well they navigate their child's illness and all the issues around it is all impacted by how things are going with the psychosocial environment in the family. How able they are to meet those challenges, and we can make a difference in helping hook these families up with help that they need. I learned that it's a team-based intervention. So that's critical, is having that team behind you to help you address these things. Because as doctors, as providers, no, we don't have time to do everything justice. And so we need to rely on our team. And so having clinic staff, and then for us having Castell also has been instrumental and essential in helping us wrap our arms around families getting the help that they need. One quick experience I'll share is that we had a baby who I saw as a newborn. It became apparent through this experience in conversation with families that this family was struggling financially. They were living with friends that had housing insecurity, food insecurity, late to prenatal care because mom found out she was pregnant later on in the pregnancy, and so really had very low amount of resources. And we referred them to Castell, our care coordinator, helped them get set up with WIC and SNAP. The baby had been gaining weight poorly during the first few weeks of life because the parents were diluting formula to make ends meet. And so there were a lot of things we could do to help them get set up with. It was hard for them to navigate paperwork and applications and phone trees, and needed quite a bit of hand-holding, which was done by our care coordinator at Castell, and finally the social worker got involved. And I was able to follow with the baby for several weeks, educate them on formula, got them help, some samples to get through until they were approved through WIC, started getting formula there. they found a trailer in Colorado City, which is in Arizona. And so they had to change insurance, and that was a big headache for the family. Our staff supported them through that process. The baby gained weight well, and the family got set up with a stable place to live, and help that allowed them to kind of get back on their feet. And Dad got a job, and the whole experience went really well because we had a team of people that kind of patiently worked with this family and communicated with each other, and didn't give up when it was challenging to get this family the help that they need. And so the outcome was much better than I think that if it was just me seeing this baby, we were able to give them much more help than I would have been able to do alone. So as we do this work, it changes the focus and the culture for us, and our ability to really help kids.
Awesome, Tim. Thanks. Vanessa, what's your perspective from the operations practice manager side?
Yes, good afternoon, everybody. Can you hear me, Dr. Davis?
Yes.
Okay, great. So I remember a few years back being in a leadership seminar and hearing Dr. Davis speak on this. And I was all in from the beginning because it just really pulled at my heartstrings that this would be really important work. But we come from a pediatric clinic with about 17,000 patients that we support. So we're a really large peds group. And we don't have a multidisciplinary clinic in-house, like we're just a standalone peds. So I kind of really worried about how do we start screening for these issues that are obviously adult issues without having the ability to kind of have that warm handoff to get them back plugged in with their primary care, you know, that maybe we're collaborating with under the same roof. And so those were kind of some of my initial concerns. And then, you know, thinking of our divorced families and how that can get a little bit sticky, and parents could potentially try to use this type of information to take custody of children and stuff like that. So that, and then also staffing, how do we do this important work when we're screening this often, and with all the COVID concerns and what that did to families, and how we've seen such a huge increase there. So as a manager, that was really, I understood quickly that this was important, but I also kind of worried about the challenges of staff turnover and how do we keep everybody up to speed and what that process is, because there's nothing worse than asking the question and then doing nothing. Like that is absolutely what we don't want to do. So early on, I identified like a champion in this role, like someone who could help onboard and train new caregivers, someone who was a point of contact for any questions, someone who can help role play on that comfort level of being able to say to parents, you know, oftentimes I had staff walk in with me when I had those conversations and say, you know, Dr. Larson, for example, wanted me to come in and talk to you. It looks like you've identified some resources we can help support you with. Are you okay? You know, because oftentimes we have to have them sign that consent that allows us to negotiate, you know, to communicate with third-party community resources in order to get them the real help. Just to give an additional plug to the United platform, the one benefit that has really been great with that is our team being able to upload those referrals through that you know, authorization that allows us to communicate with them. But we can see when action is taken. So if I put in the referral, I can then look to see that they've reached out to parents, that there's been communication going on. So that's been super helpful when we have like our fee-for-service patients that our team is involved in coordinating, versus when we can do a warm handoff to our Castell partners because they're our value-based care patients that then can have that more higher level of care management and social work and all that. So that has also been some of the thing, is just making sure that processes are in place so that no matter who the patient is, who their insurance payer is, we are all engaged and we have a process for everyone in order to make sure that there isn't anyone that falls through those cracks. And I would just want to do one last plug to kind of what Dr. Davis was saying, under the extreme stress. I know in my experience, on the support that I've offered from my leadership level, we have had a couple patients who have disclosed that extreme stress that have resulted in abuse towards those children. And it's been so unfortunate, but I just want to echo that seems to be one of those ones, like you kind of think of the, you know, when there's a domestic violence, that might be a no-brainer that we need to intervene more, but that extreme stress is also an indicator that we really need to say, hey, if they're reporting that, there's really something that we need to dig into to find out, you know, how we can help support them. But this is great work. I love that Intermountain's involved in it, and appreciate Dr. Davis's leadership in having us go this direction.
Thanks, Vanessa. I just love the kind of the more real, I think they give you a more real take on this. And along those lines, I also, you know, Tara Long, who talked earlier, Tara was actually the care manager in my own clinic, just at Hillcrest Pediatrics, like a decade. It's been over a decade, I think, Tara. And
Been a long time, yeah.
It's been a while. When we started this, and she didn't tell me I was completely crazy, just partly, and was willing to be able to lean into this. And so Tara's had a long journey with this, not just kind of what she does now, overseeing a lot of the support and so forth, but right from the beginning. So I don't know, Tara, if you just have kind of your subjective practical lessons and thoughts as well that you might want to share.
Well, you know, Neal, I actually brought another, I kind of came with a patient story that might help drive this home, and kind of springboards off of what Vanessa shared in terms of that emotional stress question. So essentially, you know, a story that kind of stands out to me is, you know, there was a patient who came in for their annual well child check. Parent completed the SEEK screener, and as the team was reviewing this, quickly identified that the mother had disclosed 5 positive needs, or 5 needs in the areas of kind of that emotional stress and caregiver stress kind of area. And to Vanessa's point, you know, that's a really powerful, those couple of questions are really powerful, and you really get a lot of bang for your buck with those questions. It really opens up the door to learn about what's happening within the family dynamic and the home environment, and what the parents are experiencing. And, you know, Vanessa spoke a bit about, you know, perhaps we missed a couple patients along the way, or before we were screening globally, and we had encountered a few child abuse cases along the way. I think this particular story demonstrates that we got upstream with this particular family, and we were able to, you know, potentially prevent some negative outcomes for this family and child. So again, the mom had indicated 5 positives on that screener. The medical team, you know, intercepted the screener and, you know, indicated that there were positives. They referred this kind of patient on to the care coordination team, care management team. Our process is that the nurse care manager will review those referrals first and kind of triage and identify, does this feel more medically complex and belong with nurse care management, or is this more a psychosocial scenario? So at that point, it was identified that this particular case was pretty heavy on psychosocial, and was then sent on to the social work care manager working with this clinic. So as the social worker interacted with the mom and began to understand, you know, what her concerns were and where she was feeling overwhelmed, she learned that this was a medically complex child that the mom was managing, you know, kind of on her own. Mom disclosed that it's quite overwhelming and stressful to coordinate the appointments, and that she didn't know how to ask for help. So the social worker was really instrumental in kind of coaching the mom along how this is impacting her, how this is impacting her marriage, and where she might be able to go next. So after lots of, you know, kind of rapport building and coaching with this mom, and the social worker kind of setting small goals with the mom to reach out for help to her community, to her, you know, the resources that she had in place that she perhaps was not utilizing, and lots of follow-up and encouragement between the social worker and this mom. the mom began reaching out and asking for help and getting some services in place and getting some supports in place. And the social worker was kind of helping the mom kind of combat or manage those thoughts and feelings in a different way, that she was failing if she, were reaching out for help. So really empowering this mom, to lean on her resources and ask for help. And I'm happy to report that, after several weeks and probably several months of working with this family and mom, the social worker is letting us know that the mom is in a much better space. They've started doing some counseling for their marriage, which was also a bit rocky at the time, and the kiddo's doing incredibly well. So I thought that was a really nice success story, and really demonstrates how getting upstream for some of this work can be so impactful.
Awesome. Thanks, Tara. So I hope that was useful for everybody to hear kind of some examples and like kind of the real work, not just the kind of the presentation side of it. I do want to go to the next slide if I can get this to advance. I don't know why it's not advancing. Can you guys hear me still okay?
Yep, we can hear you. Your arrow, this happens to me sometimes. Make sure you're clicked on the presentation and not on the actual Zoom, because sometimes that will cause you to not advance.
There we go. I'll do it that way. That'll work. Okay. So the question here is, I mean, I think it's at some level, it's great that there's a health system that is aligned with this and has resources to kind of work on this. That's not necessarily the case if you're in an independent practice. And we work with a lot of very strong independent practices that do really innovative and amazing work. And in my role in population health with primary children's, I have an opportunity to interact with these practices, and they're outstanding and provide some of the best care that I've seen. And being able to implement something like this is challenging in that setting as well. And so, Matt, are you with us? I tried to scroll through and see.
Yes, I'm here, Neal.
Oh, perfect. Matt, can you give us a reality check on this? I know years ago we talked about this, and I know it was something that your team was really interested in, and I know there were barriers. And so I'm kind of hoping if you can give the real world kind of check in on this, if that's okay.
Sure, and thank you, Neal, for the opportunity. Appreciate the good work that you do, and just appreciate the association. And I want to first start out by just saying I'm not here to throw water on what I think is really important work. This is something that I think we take seriously here at our practice, but there's certainly some challenges that we face as an independent practice in trying to not just do this, but other things. So I wanted to talk a little bit about that. Neal had asked that I address that. And I think also I would note that as we work towards more value-based arrangements, I think that will help in terms of how we are able to overcome some of those barriers, maybe not all of them, but some of them. So I put some of these challenges in two buckets, really financial and control, or the ability to impact the child's wellness. And I'll just start with financial. There's certain costs that are associated with this, and lack of financial alignment is on Neal's slide here. And I think that is a good way to sum this up. But as we looked at SEEK, and as we looked at trying to roll that out, we noticed there's some training costs involved in that. In addition, there's time associated with that. And many of our physicians are already working in various uncompensated roles that are outside of just their care, their daily schedule. They may sit on our board, our shareholder board. They may sit on subcommittees to that board. They may sit on other committees within the practice where they're trying to work through basic processes or policies, where we're trying to align both operational and care processes. In addition, they have other roles where they're possibly the chief of pediatrics at certain local hospitals. Some of those might be an Intermountain Hospital or others in the area. And so they're busy, very busy outside of just their normal work. So there's both a cost and a time to that. In addition, there's a cost to us internally to connect families with resources. And I liked what Vanessa said in terms of, asking the question but then doing nothing. Are we able to actually do something with the question that we ask or the answer that comes back to us? And there's a cost to that. We have what we call care coordinators, but they take care of many other things. They're not strictly like a care manager. They're doing many, many things to take some of that administrative work off of our physicians so that they can spend their time, most of it being with patients. So there's cost to that. And it's adding one additional thing that they need to do in order to connect people with resources. In addition, our EHR, I'm sure this is not a shock to most, but not EHRs, one, create a streamlined process for screening patients or for providing those electronically in a way that's streamlined. In addition, most EHRs are not just aligned with pediatrics. And so they may come up with a screening process, but it does not fit for the pediatric population when sometimes you're screening patients, sometimes you're screening the caregiver or the parent. And so that's challenging as you're trying to overcome the barriers that exist with respect to trying to make an efficient process. You have to add things on to your EHR that come at a cost. You may have to use different tools to add on to your EHR, and those come at a cost. As we looked into this initially, and this has likely changed somewhat, but the reimbursement, as we looked at various payers, some did not reimburse and some did. And so we recognize when we implement something, we don't necessarily want to do it for certain populations. We feel like we want to do it for the entire population of patients that we have. As you know, through the pandemic, we looked at this, I think it was just before the pandemic. And as we got into looking further at it, and as we entered into the pandemic, as you know, things changed. There was increasing focus on other things, and we just weren't, number one, able to focus on that. But then, as you know, costs have increased, whether it be supplies, vaccines, or just our labor costs have increased significantly over that time. And so trying to put the resources towards this specifically has been difficult. As far as kind of what I label control or the ability to impact a child's wellness, this is where as we talk with physicians, when you combine the financial constraints, there's challenges that we found. There's certainly a lack of comfort or ability they feel like to effectively address these. And I think this is where SEEK comes in, and that training is really important to be able to give the resources, the training, the confidence to your caregivers, your clinicians to be able to address this in a way that's both seems certainly sincere, but also efficient as they're trying to work through their day. They also felt like they were being taken a bit out of their scope. That I had a couple of them comment, I'm not a social worker. I don't know how to address these kinds of things. You couple that with what they feel like they are able to address. And I think some of our physicians felt much more equipped to impact a child's wellness in other ways that are not necessarily associated with SDoH. They don't say that it's not important. They recognize that it's important, but they feel like personally they have the ability to impact a child's wellness in other ways that they have more direct control over. And so that was something that, given the time and ability that they have to impact things, they felt like their time would be better spent. As you know, in private practice, just to be very blunt, in a fee-for-service world, Utah is primarily still on a fee-for-service based payment system. you have to see a certain number of patients a day and see them with good care, good quality of care. And they felt like the time that was allotted for them to do that would be very difficult to throw something additional in, because we've continued to throw additional things in to the process, especially of our well care visits, to address other things that we're trying to do to meet certain HEDIS measures. So I think those what I call control or ability to impact the child's wellness are some of those barriers when you combine them with the cost perspective. The way we schedule, we've really tried to go with a very open schedule. We have 15-minute appointments for most all of our appointments. Some are 30 minutes, but most are 15. We've gone to this open schedule to allow really, we only restrict, for instance, certain things, but most well checks, sick visits, all of those can happen anywhere on our schedule to meet access needs for our patients, also to allow patients to be able to schedule most of their appointments online. There's only a few things that we make them call in. That reduces our need to be on the phone. And also, as you know, serving pediatric patients, their parents are getting younger and younger as I get older. So they're wanting to deal with us online. And so we did this type of scheduling in order to accommodate that desire. And so that created a scenario where our physicians were being asked to then really manage their schedule. They knew that they'd need longer time than 15 minutes for some visits, but they're kind of managing that as they go through their day. And so it put additional stress on them to try and figure out how they manage that time. Again, I just end with the fact that I think this is incredibly important. We've continued to evaluate how we get to this. I think part of our sticking point is really trying to get a streamlined electronic process through our EHR. I think if we can do that, that will increase our ability to make this a more streamlined process and get less pushback in terms of implementing this at our practice. Those are my quick thoughts about some of the challenges that we faced in terms of trying to implement this at our practice. And I can obviously answer questions, but those are my general thoughts, Neal.
Perfect, Matt. Thanks for sharing that. And I felt it was really important to have that perspective for people to understand that, okay, here's this ideal, great, but the reality is things are challenging. And some of those challenges that Matt talked about really are helped with the SEEK training. He talked about the build people's confidence and things like that. And there are other things like the additional need for support and staff and EMR support and all those kinds of things that just are part of infrastructure. And that's really important. So Matt, thanks for sharing that. Much appreciated.
Sure.
Let's wrap up because I know Joey's got a couple things to share here too. So let me just move right along here. Here's the take-home points. All right. So number one, social determinants of health screening is coming, ready or not. Number two, community resources need to be good enough. They don't need to be perfect. Waiting for perfect often means they don't do anything. Number three, connecting to good enough requires support. It's actually people doing work. It's systems. It's an electronic medical record that can facilitate this. It's infrastructure. Number four, doing this work transforms culture. I don't know if you noticed when Tim said that. And that's definitely my experience. And that culture of a clinic and being able to support that family unit to get upstream, it's actually wonderful and hard. And then the last thing, and this is really important. I thought, a decade ago when we were leaning into this, oh, how great, we're going to help all these people. And what I've come to realize is that my role isn't necessarily to be a fixer and a helper. It's to be useful and supportive to these remarkably resourceful and creative and capable people. I mean, I was super quick, we can end, but I had a mom come into clinic a few weeks ago. Her little kid was wheezing, having trouble with asthma, had been in the emergency department, came in, she hadn't followed through with the controller medicines and things like this. And so people look at that at face value and say, non-compliant patient, bad parent. But I knew this family, I knew this mom because over time we had, done these screeners. She had been in and out of the homeless shelter a couple of times, had been living with her sister. And in that same month that her son was having difficulty with asthma, had moved to a new place while taking her 2 other kids to school and holding down a job. And she did get him his inhaler several times throughout the week. And so the first thing we talked about is how amazing she was as a mom to be able to navigate that. And then we moved on to help her get a better controller medicine and a little better asthma action plan. But my paradigm of that family and that system is very different. And I'm grateful for that. So let's go to the next one. All right, super quick. My favorite book is Les Miserables by Victor Hugo. And in there, he talks about this elephant. This is the elephant of the Bastille. And this is where Gavroche lived. If anybody knows the story, he's one of the little street kids of Paris. Actually, Paris, he lived in the elephant, and he actually rescued a couple other kids and had them live in the elephant too. And this is interesting because this elephant was this big plaster of Paris structure, and it was created by Napoleon. It was supposed to be bronzed, and it was supposed to represent the might of the empire he was creating. And that never happened. But what did happen, at least in the story, I love this little statement from him. God had done a grander thing with it. He sheltered a child. And I think, we pour so much resources into super fancy medical care and neat things, and that's good, and our health systems and all these kinds of things. But at some level, wouldn't it be grand if we could just shelter a child? And to me, that's really at the heart of what this is about. It's understanding that environment of a kid and being able to provide the support so they can thrive and unleash their joy and potential, as I like to say. Here's what Victor Hugo said also that I love about children. He said, "The gammon is a beauty and at the same time a disease of the nation, a disease that must be cured. How? By light. Light makes whole, light enlightens. Give them light that they may give you warmth." And to me, that's the heart of this idea that, our mission is to unleash the joy and potential of each kid. And I feel like that these processes, yes, they're coming from national forces. Yes, there's all of these things, but at the end of the day, it's about a child and about giving them that opportunity. So that's a presentation. So over to you, Joey, if there's questions or if you want to share what you want to share too.
Well, I wasn't planning on getting choked up at the end of this presentation, but you got me there with the Les Mis slide.
Yep.
Thank you.
Good one.
It is a good one. It's a really good one. Thank you, Dr. Davis and colleagues, for just having a really frank conversation about this today. If you want to stop sharing, I'll share my slides real quick and just one, as was mentioned by Matt West with We Care, and I'm a huge fan of We Care. My children went to We Care when I was a brand new mom, and I have many wonderful memories of going to the We Care clinic there at the Davis Hospital. But they do amazing work, and they're doing important things. But the challenges that Matt mentions are real and are things that we have to find ways to address. And so one of the approaches that the CDC recommends is using Medicaid, because as Matt mentioned, we're a fee-for-service kind of situation in our medical and healthcare in this state and generally across the nation. Unfortunately, that can make it difficult for smaller practices to be able to make the financial space for adding this additional screener. And so one of the things that we've spoken with representatives at the Centers for Disease Control is requesting an 1115 Medicaid demonstration waiver. So what a Medicaid demonstration waiver is it's basically an opportunity for states to approve experimental work, pilot or demonstration projects that will be helpful in promoting the objectives of the Medicaid program. And Dr. Davis, as you mentioned, CMS is beginning to focus much more on these root causes, the things outside of actual access to healthcare that impact health outcomes across the lifespan. These Medicaid demonstration waivers give states the flexibility to make their programs work better for the people that they serve within their state. And it gives them an opportunity to demonstrate and evaluate state-specific policy approaches that will better serve those populations. So to give you a little bit of an idea about cost, and again, and you'll notice that numbers on this are a little older. These are, Dr. Davis mentioned some of the work that was done initially I'm spacing on his name right now.
Dr. Dubowitz.
Yes, that's it. Dubowitz, thank you. So what we know based on 2009 dollars is that every case of child maltreatment costs Medicaid about $2,835 per year, and generally span about 4 years until they're resolved. The average cost of SEEK implementation per child per year averages between $2.54 and $4.23, which leads to an approximate $189.10 for each case of physical or sexual abuse that is averted. The average lifetime cost per case of non-fatal child maltreatment to Medicaid is $830,928. That was in 2015. And as we know, costs have only increased. They've only gone up. And of course, that impacts the cost of implementing SEEK as well. But where the growth in these numbers is from 2015 to 2023, I would be interested to see how much that's changed, but just giving us an idea of what the average lifetime cost per non-fatal case of child maltreatment. So we're going to, an example that was provided to me by colleagues at CDC was Washington State. In Washington State, they have about 460,000 children who are under the age of 5. And Medicaid covers about 30% of the kids in Washington State. If we average out the cost, the high end and the low end of the cost of implementing SEEK and average it at about $3, that equals about $525,000 per year, and over 4 years, that's about $2 million. In Washington, in the year that this study was done in 2017, they reported 95,600. I'm sorry, that shouldn't have a dollar amount there. They reported a total number of cases of 95,603%, with about 61% of those involving children who are covered by Medicaid. It's estimated from the original study that about 31% of cases could have been prevented through the implementation of SEEK. If SEEK had been implemented to fidelity, care services had been able to come in and address some of those issues that may have negative impacts on a child's health across the lifespan. This led to a Medicaid savings of over $51 million to Medicaid over 4 years. When you take away the cost of implementing SEEK, that leads to about $49 million in dollars saved for the Washington State Medicaid program. And so I just wanted to kind of share this really quickly, just to kind of put into perspective the overall cost to implement SEEK versus the overall cost of what it ends up costing taxpayers and families who are individually impacted by child maltreatment over the lifespan. And so just wanted to kind of share that. It is something that we would like to explore in looking at a possibility of a Medicaid waiver to address. I mean, we can't address all of the issues that Matt with We Care mentioned, but that would at least provide a little bit of that financial backing so that smaller practices would have an avenue to move forward in implementation. So we did have some great questions that came in over the course of the presentation. So I'm just kind of going to go through them from the beginning. And Dr. Davis and colleagues, we would love to have you chime in and answer some of these questions. I know the answer to this one, Dr. Davis, but I'd love for you to just mention it. How many IHC clinics are implementing SEEK, and how long has it been being implemented?
So there are 17 pediatric practices now, and they all were fully implemented in 2019. And there was a gradual buildup over the prior 7 years to get to that, and then full implementation for pediatric practices. And right now, it's being implemented in all the family medicine practices, and there's a lot of them, 30, 40, something like that. Yeah.
Fantastic. Thank you for, and I would just like to, you mentioned when we were chatting, preparing for this today, Dr. Davis, that what is the percentage of Utah children that are seen at IHC clinics? I think that you mentioned that.
Yeah, it's going to be around a third or less than a third. So the majority of kids are seen in the strong independent practices. Like WeCare is one of them, and there we have a network where that's a part of my role that I love. I get to work with the leaders of all these practices. That's how I know Matt and have so much respect for him and his team, and their ability to innovate and do things is tremendous. Matt didn't talk about all of the awesome innovations they have done there, but I could, because I know his team related to some of their outreach and their access and other things. But the point is, there's great care being provided, and to support those practices to be able to take a step into some of this area, yeah, it would really help to have for that Medicaid waiver. I think that's absolutely true.
Absolutely. And I that's one of the reasons why I wanted you to kind of drive that point home, that we're only looking at about a third of kids who right now, due to the fact that they're seen through IHC, have access to this screener. And so it just kind of really clarifies the need to find a way to make this implementable in other practices. The important work that's being done in smaller, strong, as you mentioned, strong independent practices. And so thank you for clarifying that. Nathan asked a question in the chat, and there was a really good answer in the chat as well from someone from Holy Cross Ministries. But what happens when you have a positive screening for domestic violence or intimate partner violence? I mean, can you walk us through, like, what would happen in that kind of a situation?
Yeah, great question. So one of the things that, and Tim and Vanessa alluded to this as well, is there's training that goes on for the staff, and Matt talked about this too. There's training that's required as you implement SEEK. And so part of that is being able to understand, I see this, help me understand this. And then there's an algorithm that people can use. That what I typically do is be able to connect to the Utah Domestic Violence Coalition. If you know about that, the link line, is everybody familiar with that? But they're professionally trained resources to help families navigate things. And I'll mention one other thing about this, because I think it's important. Our detection rate for intimate partner violence is certainly lower than what's actually existing in the population. I think it was around 1.5% or something. But what we have, again, it's about the culture. Our staff has been trained. We've been trained, not that we're experts, but we have an understanding and I think a compassion around these things. And in our each exam room, we have little tear-offs for the Utah Domestic Violence Coalition. You can, it's a little tiny little perforation, you just tear off the phone number. The amount of times that we replace that in the bathrooms and in the exam rooms far exceeds the number that is disclosed. So it's not, there was a great paper that came out just in June from the American Academy of Pediatrics that said for pediatric offices, yes, it's useful to have a way to screen. It's more important to have a culture of safety where people can get the information they need. If they're in a spot where they, as a resourceful, capable person, are wanting to disclose and have that kind of support, we're there for that. If they want that information and be able to take that and move forward without disclosing, that's also fine. And so being able to have both the questions and the culture with the information available to people seems to be the critical thing.
Absolutely. I think that point you make is really the huge takeaway, is that you're creating a culture and an environment where there is a trust and
Yes.
a trust where that sort of help seeking can happen, and you won't, and that's a difficult thing. And I think that's one of the great the great things about these sorts of screeners is that you're giving them an opening to have these conversations.
Yes.
Very often they're not quite sure who to talk to about help. This isn't an asthma thing. This isn't my kid has a cold thing. This is how do I make sure I have enough formula to feed my child, and so you're really opening that avenue for those conversations to take place in a safe space. And I think that is really powerful. I appreciate too that you mentioned that there are trainings that will help
Yep.
staff become comfortable with this, but it's not just a one-off, right? You don't do a training to begin and then you're done. You have additional booster trainings that take place.
Well, in order to implement Sync, there are initial trainings and their videos, and they are quite good. And then the Seek itself doesn't have like a follow-up training that's required every year or something like that. However, as we work as a system and collaborate and coordinate, we absolutely do that. And especially the resource builds up over time.
Fantastic.
For the capability to respond, I should say. So again,
Yeah.
perfect is the enemy of the good on this. Being able to have a good enough response leads to a better response over time.
Yeah, absolutely, for sure. I would refer folks to the chat. Carlos Flores with Holy Cross has written out really interesting information there about how Holy Cross addresses domestic positive screenings for domestic violence, and mentions here too that IHC that they would love to be connected with the IHC care management team, because a lot of the people that they see there at Holy Cross Hospital are seen at IHC clinics. And so appreciate you bringing that up, Carlos. And I would you'll get contact information and stuff at the end, or as we send out the follow-up email. So yeah, I would love for that connection to take place and to hear about it later if that does happen.
Yeah.
Okay.
So, yeah, email us, Carlos. We'd love to hear from you.
Yeah, fantastic. So there's been lots of interest and questions in the chat about Unite Us, whether or not there's a cost, how folks access. Is there anyone who just would like just to give us a little bit more information about Unite Us? Because it sounds like there's a lot of interest for folks in schools and other areas to be able to access that resource to benefit the kids they serve.
Yeah, Tara, I see that you're still on. Do you want to take that one? Because I think you probably know better than I do.
I'm sorry, will you repeat that question?
Sure, you bet.
Yeah.
Go. You can go, Jody.
Okay.
Or Joey, sorry.
Tara, there have been lots of questions in the chat about Unite Us, how folks can access it, whether there's cost involved. Can you just give us a little bit more information? We've got partners here on the call from other areas, other fields, who are interested in seeing how they might be able to implement Unite Us in their work.
Yeah, of course. I do believe that there has to be somewhat of a licensure kind of purchased, or at least some sort of licensure agreement in place. I don't know if it's necessarily a purchase. I mentioned that because I have recently run into a little bit of an issue with perhaps for example, University of Utah clinics not being kind of licensed or included in this licensure with Unite Us. So I see in the chat that someone dropped the name of Letitia Goodman at uniteus.com. She would be a great resource to get your group going on that, or learn about what those options are. Essentially what that looks like for Intermountain employees is requesting access through our, kind of our access hub. And then we usually have Letitia and or her team members do a demo for the team as they're gaining access and that sort of thing. And then from there, it takes Unite Us a bit of time to build a portfolio for that particular clinic or hospital organization or whatever it may be. And then once that is done, I think you're good to go from there.
I think too that I think reaching out to Letitia is a good idea. It's much easier for our system to support that connection to community-based organizations. So than it is in some other settings. So people who are here from community-based organizations that are providing service to the community, that's what it's for. And so reaching out to Letitia, or I put Jean Smith in the chat as well, or to me if you can't get a hold of them. But there's a way to make that happen for you.
Fantastic. I see that a question was asked about whether or not SEEK screenings took place in other languages, specifically Spanish. Dr. Davis did answer that yes, it is. The social determinants of health screenings that will be done there at IHC will also be performed in Spanish. So we're really thrilled to hear about that. We're coming to the end now. There are some, most of the other questions I think we've pretty much answered. There was one more question about whether or not there were any plans to implement the SEEK screener in OBGYN offices, or like if a child is in NICU and is receiving care there, if there are any sorts of screenings going on in that setting. You know, you mentioned children with special healthcare needs, the higher risk, the higher strain and stress on parents. So what have you looked at anything like that?
Yeah, so within OBGYN, they also use the social check tool that I mentioned for the kids, for people that are 6 and up. And then similarly, at Primary Children's now, they're just implementing that across the multi-specialty groups and so forth. Tara's actually doing a lot of that work. And then I should mention, like in the NICU, there are social workers and things like that to help work with families also. So the nice thing about SEEK and so forth is that it's universal. It's for everybody to be able to understand.
Hey, Neal, can I ask just a quick follow-up question? Sorry, this is Emmy from Holy
Sure.
Cross as well. Neal, is SEEK only, I mean, because I think you kind of led with this, it just said this, can SEEK be used in community-based agencies like ours, or is it really only meant for medical practices?
Yeah, great question. I mean, I think you'd have to email Howard about that, Howard Dubowitz, but it's really designed for pediatric primary care. Having said that, I mean, it's a very usable tool. And so, you know, potentially could be used in other places too. Oh yeah.
Well, and I think I was thinking of it
website.
more like
Thanks,
in
Joey.
partner. Yeah, and I think I was thinking of that, Neal, like more in partnership. Like we do have community health workers in various like FQHCs and clinics. And if this could be a tool where we could again support the physician practices in helping to do those screenings, especially in a bilingual, bicultural way, and you know, kind of garnering that trust of clients. I was just thinking if our teams could be trained on that, that'd be something we'd love to, as a community partner, to help the medical side with.
Yeah, I think that's a great idea. And there are other tools out there now too. SEEK is the one that has the randomized control trial and is focused on child abuse prevention. That's why I like it. You'll find other tools that are also useful, and other children's health networks around the country are using tools similarly to be able to do that screening.
Wow, what a rich and wonderful conversation and discussion, and an important approach to addressing issues before they become issues in the pediatric setting. Just a reminder, these events are only made possible by attendance and also evaluation. So we've got a link to the evaluation in the chat. If you take just a couple of minutes, click on that link, fill it out, give us your feedback, let us know how it went, how you felt about it, and let us know if there are any ideas that you would like us to consider covering in our ACES Learning Collaborative in the future. We'll see you again, hopefully in September, when we'll be having Julie Holt-Lundstad from Brigham Young University come and talk to us about the science of social connection and the impact of social isolation on long-term health. Thank you all for your time. We went a minute over, but we came in pretty close to our time. So thanks, everyone. I hope you have a wonderful day, and please feel free to reach out if you have any additional questions. Recording and slides will be sent out following the event. Thanks, everyone. Have a wonderful day.